This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2023, all rights reserved. My name is Doug Lair, and I will serve as your moderator for today. I am a registered respiratory therapist, fellow of the AARC, and its chief operating officer. Welcome to today's program, Evaluation of a Closed Suction System with Integrated Tube Scraping Technology. Upon completion of this AARC JournalCast, participants will be able to 1. Identify the research question of the study. 2. Identify the study design. 3. Discuss the main results of the study. And 4. Discuss the implication of the study on patient care. I am pleased to welcome Dana Evans. Dana is a fellow of the AARC, is the Midwest Region Respiratory Care Director for Advocate Health, and she currently serves on the AARC Board of Directors as a Director at Large. She serves on the Advanced Practice Respiratory Therapist Committee and is Chair of the AARC Program Committee. Dana also serves on the Respiratory Care Program Advisory Board of several colleges. Neither Dana nor I have any relationships to disclose. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Today's presentation will include some specific technology as it is listed as part of the study. Dana, welcome to today's program.
Thank you, Doug. Thank you so much for having me here today. Thank you for that lovely introduction. I am really excited to be here today to discuss this really well-written and well-done paper and research project with you over the next hour or so. So just jumping right into it, for this project, when I'm reading research, the first thing I like to look at is the study aim and research question. So for this project, the authors sought to understand the impact of endotracheal tube scraping devices on mechanical ventilation duration. This was their primary aim of the project. They also sought to understand the impact of the time to first successful spontaneous breathing trial, length of stay both in the ICU and the hospital, and overall incidence of ventilator-associated events. Those were the secondary aims of this project. Now, I think we can all agree that these aims are clinically significant and can have substantial impact on the work that we do every day in our critical care units, as I'm sure we are all interested in ways to reduce mechanical ventilation duration, length of stay, VAP, VAE, and things like that. So let's start by looking at some of the previously published research that's been conducted in this area to kind of get a sense of what is already known about this subject. So I want to begin by talking about endotracheal tube obstruction. So I know any one of us that has ever extubated a number of patients, particularly in the adult ICU, can absolutely attest that many ET tubes are filled with mucus when we pull them out of our patients, right? Sometimes, you wonder how the heck were they breathing through that thing? It's so occluded with mucus. So it would seem logical then that removing those secretions would have benefit to our patients and really enhance the care that they receive. This particular study that you have in front of you by Moderator and colleagues was a small study that assessed luminal narrowing and mucus distribution in endotracheal tubes post-extubation using high-resolution CT they looked at the data and they saw where the mucus was distributed and where the narrowing was, and then they took brand new endotracheal tubes and actually mimicked that obstruction by partially filling clean endotracheal tubes with silicone, so they could evaluate the impact of that luminal narrowing on airway resistance to flow. And what they found, I'm sure you're not surprised, is that luminal narrowing is common and that it correlates with increased resistance, right? So less room in the tube, harder to breathe, we all know that. The question here really becomes, though, does that increase in airway resistance translate into an increased work of breathing? And taking it a step further, does it have any impact on significant patient outcomes? Here's another study by Brady and colleagues. In this particular prospective observational study, it was a small study, subjects were included if they failed at least one spontaneous breathing trial and also had an airway resistance of at least 10 centimeters. The authors were seeking to determine if the impact of tube scraping, what the impact was on tube scraping, if it would reduce airway resistance, and what that would ultimately do to the success rate of spontaneous breathing trials. What they found was statistically significant improvement in resistance post-endotracheal tube scraping. That makes sense, right? Get the mucus, get the biofilm out of the tube, easier for gas to flow through there, reducing airway resistance. Interestingly enough, though, the authors found no difference in the pre-post scraping airway resistance in those patients who passed spontaneous breathing trials versus those that failed. So this could mean that the authors chose an airway resistance that was too low to be clinically significant, or perhaps that airway resistance has less impact on spontaneous breathing trial success than we may have previously thought. In this instance, the authors did suggest that future studies were needed to determine what level of airway resistance at which ET tube scraping would impact SBT success. Kind of interesting there. There are several studies that evaluate the same thing, that are looking at the impact of removing that obstruction, removing that mucus from the ET tube has on airway resistance. And not surprisingly, they all found that removing that does reduce airway resistance. Here are just a couple of options, a couple of examples of additional studies that found that. There are several more as well. This particular study is a randomized control trial of 74 adult patients that were expected to remain intubated for at least a couple days, 48 hours. Subjects were randomized using a 1-to-1 ratio, so half of them ended up in the control and half in the treatment. The treatment group in this study received an ET tube cleaning protocol that involved tracheal suctioning immediately followed by a single pass of scraping the tube every 8 hours, so 3 times a day. And then patients in the control group got the standard of care, which was suctioning via the standard closed inline suction catheter, also regimented 3 times a day, every 8 hours, but also as needed for both of those patients. And so what they were looking to see was the impact of that cleaning. And what they found was a couple of interesting things. So the first thing they did was, so they actually assessed this all post-extubation. So they collected the endotracheal tubes of these patients after they were extubated, immediately post-extubation, and did something similar to what a previous study did by assessing the mucosal distribution using high-resolution CT analysis. Additionally, they sent mucus samples off to the lab for analyzation. And so what they found, you can see some pictures of the images from the CT there in the lower right-hand corner, where the narrowing of the lumen is occurring from the mucus stuck to the walls of the endotracheal tube. Not surprising, endotracheal tubes that were treated with tube cleaning, so tube scraping with that device, did have significantly less mucus accumulation, p-value there of 0.004, and were significantly less occluded than the control group where there was no sweeping performed. They just had standard ET tube suctioning. So we can see here from these studies that cleaning the ET tube with these tube scrapers, balloon sweepers, cleaning devices is effective in removing mucus from the endotracheal tube wall. And again, the question is that clinically significant? The other thing that these studies look at is the impact of tube scraping on biofilm accumulation and the resultant VAE that can come along with that. And I think, just taking a step back for a moment, it's well known that the presence of biofilm, or well thought that the presence of biofilm plays a substantial role in the development of VAE and infection-related ventilator-associated conditions, because biofilm, frankly, harbors microorganisms that can lead to infection. We know that VAP is the most frequent healthcare-associated infection in the ICU and results in increased morbidity, mortality, length of stay, raises the cost of care, a whole host of things. And you can see there are many studies here, and there are so many more. There's just a few I grabbed that identify the correlation between biofilm and the development of VAP or VAE. I will just mention briefly that no discussion of VAP is complete and the airway without talking about all the other things that can lead to VAP. We know it's a very complex, multifaceted disease. That's why we have VAP bundles that include a whole host of things. But when we're talking about the airway specifically, the other concern is for microaspirations of secretions to sit on top of the cuff due to very small folds in the cuff itself. There have been lots of products that look at trying to suction those secretions above the endotracheal tube cuff to prevent the microaspiration. So that's out of scope for this paper, but when we're thinking about tube scrapers, as is the case today, we're thinking about the biofilm on the inside of the airway exclusively when we're thinking about the impact it might have on VAE. So just one small piece of those things that can lead to IVAC. But I want to go back, having said all that, I want to go back just for a minute to the study by Pensaroli and colleagues with the high-res CT analysis of the tubes post-extubation. They also did, as I mentioned, sputum samples of the mucus and sent them to the lab for analyzation. Interestingly enough, they found no statistical difference in the microbiology between the ET tubes in either group. So it didn't make a difference on the organisms that were found in the airway. So building on that, this study that was a small observational study published in 2017 by Bards and colleagues, they looked at ventilator parameters, but interesting here, they also looked at staging biofilm in the tubes, as well as the pneumonia rate of patients who were suctioned using a tube scraping device versus a standard inline closed system suction. They found no significant difference in any of the measures evaluated, including the biofilm stage, pneumonia rate, or changes in tidal volume and peak pressure post-suctioning. So kind of interesting. So kind of putting all that together, what do we know about this subject? We know from previous research, and it sort of just makes sense intuitively, that tube scrapers are able to reduce mucus accumulation and occlusion in the endotracheal tube. We also know from published data that this can result in a reduction of airway resistance. What isn't super clear here, as I said, is does this have any significant impact on clinical indicators like length of mechanical ventilation, length of stay, things like that. So this is one of those things this paper did seek to answer. Now, I just want to take a brief minute. So, I did a literature search for this, read the paper, read lots of papers to try to understand the current knowledge on this subject. But one of the really nice things that the Respiratory Care Journal is it has this section called the Quick Look, and you can see on your screen there this box for the quick look, and it really does a nice job of summarizing the current knowledge in this area as you go into reading the paper. So it gives you a nice, succinct, and really concise look into the current knowledge as you dive into the research. So in this case, The journal has here that endotracheal tube narrowing due to secretion accumulation or biofilm formation can increase airway resistance, makes sense, or cause total airway occlusion, and ET tube clearance devices have been shown to be effective at reducing luminal biofilm secretions and raw airway resistance. So if you're not someone that takes a peek at this quick look, I would encourage you to do so. It's just a nice little quick overview into the current knowledge. And later when we talk about what this paper contributes to our knowledge, that's also in this box as well. So it's just a nice little peek that the journal does for us. Okay, so I want to talk about conflict of interest because this is a really important thing for us as consumers of research to be thinking about when we're reading articles. You have to look at the conflict of interest associated with the authors of the paper and those associated with the research itself. Now, many researchers have conflicts of interest that they disclose. It may or may not have relevance on the findings, but you should always be thoughtful about research conducted by individuals who have a vested financial or other interest in the potential outcome of the data that's being presented to you. Conflicts of interest are usually easy to find in peer-reviewed publications, so I encourage you to have a peek at that while you're perusing the article. In the Respiratory Care Journal, they put it up pretty front and center, usually on the second page. You can see it's kind of highlighted here for you on your screen. If I were to blow that up so you can actually read it, we'll talk about the conflicts for the authors on this paper. So in the first paragraph, you're going to get a summation of where the authors work. The second paragraph is where the disclosures actually come into place. So of interest here, we do have two authors disclosing some significant relationships. Dr. Scott disclosing that he has relationships with Teleflex, Aerogen, and Medline, and Dr. Vines disclosing relationships with Teleflex and the Rice Foundation. This is significant because as we dive into this research, you'll find that the product being evaluated is a product that was being sold by Teleflex. So that's something to keep in the back of your mind. The other thing here to think about is the next paragraph. So this study was funded by an investigator-initiated research grant from Teleflex. So Teleflex did provide monetary support for this work. Certainly probably paying for the equipment and other things associated with it, so it wasn't out of cost for the organization. The really important thing that I want to draw your attention to is the next part of that sentence. The sponsor, Teleflex, was not involved in study design, data collection or analysis, or manuscript preparation. So while they provided funding to support the work, they did not have a voice or inclusion in how the study itself was designed. They did not have a voice or inclusion in the data, the way it was collected or analyzed, and they were not participating in the work that you're reading here with the publication. So that's a really important thing to catch. I think when we think about conflict of interest, like I said, it's something to keep in the back of your mind. But as I look at this, this is a really important sentence saying that the study sponsor themselves were not engaged in this work. Okay, so I want to go back to the study itself, just recentering ourselves around the study aim before we move on. So again, they're looking at the impact of endotracheal tube scraping devices on mechanical ventilation, time to first SBT, length of stay, and incidence of VAE. And with that, we'll jump right into the methods section of the study. So I will tell you, I am guilty of this. I will read the background and I'll read the conclusions of a study to see if I'm interested in it. It's something I want to learn more about. But the methods of the study are a really important thing to catch. A lot of people skip over them, but this is where you can find if there are issues in the study design or if there are limitations or things that you might question that might lead you to question the outcomes. And it's also a really great way to learn about research and how it's conducted. So I strongly encourage you to take some time when you're reading research to really dig into the methods and understand how the researchers developed the project. And sometimes they'll tell you a little bit about their decision-making process as well. So that's really, really nice as a consumer of research and someone who's trying to learn more about research to spend some time looking at the methods section. So this study was a single center, prospective randomized control trial conducted on adult patients between October of 19 and October of 21 in a large academic medical center. So I think we all know that randomized control trials are considered the standard when we're evaluating data. It's the highest level of data that one can have. Inclusion criteria for patients enrolled in this study were adult patients, so those greater than 18 years of age, admitted to their medical intensive care unit and on mechanical ventilation for a minimum of 24 hours. They did exclude patients that were pregnant, had a trach, were on ECMO, or who had been transferred from an outside facility and received less than 24 hours of mechanical ventilation. During that 2-year period, they enrolled 272 adult subjects who were randomly assigned to 2 different groups using a 1-to-1 ratio to either the endotracheal tube suctioning via standard inline suction catheter group or ET tube suctioning and scraping via the inline suction device with balloon sweeping technology. I want to mention just briefly, so they mentioned that they randomly assigned their patients using a 1-to-1 ratio. And what that literally means is doing a randomization with a 1-to-1 ratio means that they were seeking to have groups, so into the intervention group or the experimental group and the control group that ended up, being the same size, the same number of participants. So in this case, there were 272 adult subjects. So doing a 1-to-1 ratio, splitting that in half, that means there were 136 subjects in the control group and 136 subjects in the experimental group. That doesn't mean that they, did one and the other and then one and the other and back and forth. What they actually did was computer generation randomization. So they had a computer program randomly generate numbers. Those numbers were placed into sealed envelopes. And then the researchers, when the next patient came up for randomization, would grab the next envelope. And whichever number was in that envelope corresponded with the group for which they would be assigned. And so that's how they end up with equal numbers. But still having a good randomization process. Okay, so rolling back to the control group. So subjects in the control group, those 136 patients, they had a standard closed system suction catheter in line like we all commonly see that was placed on those patients within 24 hours of intubation. Suctioning of patients were performed using departmental policy, so advancing the suction catheter until resistance is met, pulling back a bit, and then suctioning for no more than 15 seconds in duration, so pretty typical. And the frequency of suctioning was determined by clinical needs, so the respiratory therapist determining when those patients needed to be suctioned. In the experimental group, same kind of idea, except patients had an ET tube suction catheter with a balloon sweeping technology placed in line within 24 hours of intubation. Again, like the control group, suctioning was performed in the same fashion per departmental policy with the frequency determined based on clinical need. The difference here is that the ET tube was cleaned using that balloon sweeping technology each time the patient was suctioned. Now let's have a look at this device. If you've never seen one of these, both of these images are of that device. So on the left-hand side, it looks a lot like an inline suction catheter. It's just got some fancy things on it here. So the big difference is the balloon, the scraping balloon, which you can see at the distal tip of the ET tube there. So this balloon remains deflated until the suction catheter has been passed into the airway for the suctioning maneuver. So you advance the suction catheter into the airway until you meet resistance, and then you would inflate that scraping balloon for when you pull it back out through the airway. This is a suctioning device as well, so when the balloon is inflated, all suctioning is done in that lateral suctioning port you see pictured there. The intent of this is as the balloon is scraping the mucus off the endotracheal tube wall, that suction catheter above the suction port above the balloon is sucking in all that gross stuff, right, coming off the endotracheal tube wall. For both groups, the control group and the experimental group, each patient, just like standard organizational protocol, was assessed daily for their ability to perform a spontaneous breathing trial. And spontaneous breathing trials were considered successful if the RSBI was under 105 after 30 minutes. Additionally, all patients were placed on that standard, that prevention bundle that we all use, right? So head of bed, 30 degrees, monitoring cuff pressure, deep vein thrombosis prevention, daily sedation vacations, things like that. Okay, so here's the flow chart of inclusion and exclusion into each group, and I want to talk about just the top half for a moment here. So they actually assessed 417 patients that came into that medical ICU for eligibility, but ended up excluding about 145 of them. Some of them were only intubated, about 62 were only intubated for less than 24 hours. Another subset of them presented already with a trach in place, and this happens. 18 patients were included because the research staff simply was not available to randomize them upon their arrival. So that's how they ended up with 272 subjects, with 136 in the standard ET tube sectioning group and 136 in the ET tube scraping group. So why 136 in each group? This is an important number and one that was chosen with intention by the by the researchers. They didn't just get to 136 and stop. They were shooting for 136 because power and sample size estimations are used by researchers to determine how many subjects are needed to adequately answer the study question. In this case, they were powering the study, and in other words, identifying the sample size needed in order to adequately answer the question about the impact of tube scraping on reducing duration of mechanical ventilation. If a study is underpowered, you really cannot make clear conclusions for impact based on the outcomes of the study. So for this project, the authors did identify a power of 0.8. That's a pretty common standard that you'll see in the literature, although power can range between 0 to 1, closer to 1 to better. Anytime you see a power less than 0.8, it would really be too low for most areas of research, not adequately powered. So again, it would make it difficult to make assumptions and really make clear decisions based on the data if it's underpowered or if the sample size was not large enough to assess that primary aim. So there's a mathematical equation where you use power and alpha to determine the sample size, and that's where those 136 numbers came from. So it's based on this power of 0.8. Now you may recall there were several secondary aims for this project. While they assess them, and the data for that is really important and very helpful to guide clinical decision making, the study was not powered intentionally to assess those. So we just have to keep that in the back of our mind. That cannot be the definitive end-all, be-all, end of the sentence on those secondary aims. I do want to briefly talk about alpha. Because the authors did mention that they selected an alpha of 0.05. This is also pretty standard, just like the power of 0.8. So when you're reading research, we always look at the p-value. Pretty commonly accepted that a p of less than 0.05 is statistically significant. That's actually because the standard alpha is 0.05. And you know, putting that into words, what does that literally mean when you're thinking about an alpha? Well, it means that with an alpha of 0.05, the investigator has a 5% chance of incorrectly rejecting the null hypothesis. Or in other words, there's a 5% chance that your sample data would indicate that the intervention led to impact when in fact it didn't, so a false positive. So you want to keep that number really low, so that the likelihood of a false positive or incorrectly rejecting the null hypothesis is also really low. Real simple, a statistically significant p-value is one that is less than the alpha, which is why you always see a p-value of less than 0.05 as the statistically significant number and one that is commonly accepted in research today. The authors did do a pretty rigorous statistical analysis of the data that they found. Variables that were presented as frequency were analyzed using either chi-square or the Fisher-Exact test. Continuous variables presented as mean plus or minus standard deviation or median and analyzed using the t-test or Mann-Whitney test. And again, as I mentioned, a p of less than 0.05 was considered statistically significant for this work. All right, so moving into the results of this study, the first thing we want to do is look at the characteristics and differences between the two study groups. So let me pull up here. This is the table 1. This is the baseline characteristics of the subjects in both the suctioning group and the scraping group. Ideally, your control group and your intervention group from a demographic and baseline characteristics perspective would be very similar. You don't want to see any statistically significant differences between the groups because if you do, those differences really could have an impact on the total outcome data. So as you see here, they looked at things like age, sex, BMI, sepsis score, race, primary diagnosis, big deal, the reason for intubation, tube size, were they on the VAT bundle, things like that. And what you can see is that none of these baseline characteristics rose to the level of statistical significance, meaning that these groups are very similar in composition, which is great. The only statistically significant thing that they did find different between the group is the overall suctioning frequency. So the suctioning frequency between the two groups didn't vary, but the suctioning frequency per ventilator days was significantly higher in the ET tube scraping group. But again, the average scraping, again, the overall frequency didn't differ. So a slight difference there, but the demographics were very similar between the two groups. So moving into the data and what they found and what that means, the researchers of this paper actually did analyze this two different ways. They did an analysis of the intent to treat and per protocol groups. So, if you've not heard of that, what the heck is that? So this is a direct quote from the article you have in front of you. Intent to treat is just a method of analyzing results from a randomized controlled trial where every participant that was randomized into a group is analyzed regardless of whether or not they continued on the protocol as expected. Right? So anybody that's analyzed is included in here. This is pretty commonly what we see. So if you go back to that flow chart I showed you a few minutes ago, that's the top box, right? So that 136 and 136, that's the intent to treat groups, and those are the groups that were subject to the intent to treat analysis. And I'll show you the details and the outcomes of that in just a moment. But first, I want to talk just a smidge about what the per protocol analysis is. So a per protocol analysis is just a comparison group where some subjects have been removed from the group. So anyone that was that did not complete the treatment plan as originally sort of laid out by the researchers, they would be pulled from the study group for a per protocol analysis. So in this group, just to kind of put to put this all together, in this paper, the intent to treat analysis, again, included all randomized subjects, so all 272 of them, 136 in each group. But the per protocol analysis only included randomized subjects only included randomized subjects who had planned non-terminal extubations. So that reduced that group to 156. And I'm going to show you here who was eliminated from that per protocol assessment. So the bottom part here, you can see the standard ET tube sectioning group excluded an additional 62 individuals, 29 of which were compassionately extubated, 27 died, 4 pulled the tube out themselves with self-extubation, and 2 ended up on mechanical or ECMO. So that group in the per protocol analysis ended up with 74 subjects. In the ET tube scraping group, same thing. They excluded 54 people for those same reasons, ultimately ending up with 82 people in that group. So we'll look at the results for both the intent to treat and the per protocol analysis. It's important to look at both because you could, in fact, see differences in the data. So, for example, you can see one of the secondary outcomes here listed on the table is the need for reintubation or non-invasive ventilation within 48 hours of extubation. One could reasonably say that a patient that self-extubates maybe wasn't ready for extubation, right? So they could end up reintubated or on NIV within 48 hours, and it really wouldn't mean anything about whether or not tube scraping had anything to do with that. So they just didn't follow the standard protocol for care. So that's how those patients get pulled out of a per protocol analysis. Another example might be a patient that progresses into ECMO. Right, so their time to for successful SBT probably would be elongated compared to their counterparts. So looking at both of these things is helpful sometimes if you want to find some differences in the groups and impact on the impact of the intervention. In this case, again, the primary outcome assessment being duration of mechanical ventilation, you can see in both the intent to treat analysis and the smaller per protocol analysis, duration of mechanical ventilation was not statistically impacted by tube scraping, meaning tube scraping didn't have an impact on ET tube or mechanical ventilation time. When we move on and look at the secondary outcomes, time to first successful SBT, requiring non-invasive ventilation or reintubation with 48 hours, length of ICU stay, length of hospital stay, VAC and IVAC. Again, we see no statistical differences between these groups, standard suctioning and scraping. So again, you could say here that there's no impact on these things based on tube scraping. Now, I will remind you that the study was not powered to really truly assess these secondary aims, so it can't be a period on the end of the sentence here. So I would say future trials probably need to be done to determine, there's more strongly powered trials need to be done to determine if there's any true impact on VAE when tube scraping is employed. But you can see in this group there was no impact. Nothing statistically significant and no impact on duration of mechanical ventilation, again, what the study was powered to look at. The authors went a step further and did an intent to treat analysis on patients that had been intubated for greater than 2 days, so greater than 48 hours, noting that this group is probably at greater risk for more substantial biofilm development in the airway, wondering if there would be some statistical significance here. But once again, there was no statistically significant difference between the control and intervention group for either those primary or secondary outcomes. So moving into discussion, right? What do these findings really tell us? What do they teach us? How can it impact our clinical work every day? We know that from previous studies that we just talked about that tube scraping devices do reduce luminal narrowing and mucus accumulation, ultimately reducing airway resistance. In this case, though, the authors demonstrated that the use of tube scraping devices just don't have a statistically significant impact on important clinical indicators. And then again, the results between the intent to treat and per protocol analysis were no different. So based on this, the authors would suggest that ET tube cleaning devices don't need to be used as part of routine airway management, but perhaps they could be used in select patients that have evidence of ET tube luminal narrowing noted by an increased airway resistance. I would say that future studies here are needed to clearly understand which patients would benefit from endotracheal tube cleaning or scraping. This study did have some limitations, starting with it is a single center trial. So because they had institutional protocols and processes, one has to wonder, would that work then be translatable if it went to a second center? Multi-center trials do tend to be, a higher standard of evidence, but this was a single center trial. The experimental group could not be blinded to the clinicians. It's pretty obvious when you're RT holding a suction catheter, if it's a regular inline suction catheter, or if you're, inflating a balloon to pull biofilm out of the airway. So that's not possible, can't be blinded. It could have led to some differences in behavior in those clinicians, but again, not really something that you can adjust for. The authors did note one potential additional limitation, that suctioning was left to the discretion of the clinician based on clinical need rather than as part of a scheduled regimen. Like, we saw that one study that was 3 times a day Q8 with suctioning. Although I really think this makes the data more reflective of reality and the care that we provide to our patients, because, most commonly we suction at our discretion as opposed to in a scheduled fashion. So the authors listed this as a potential limitation. I'm not so sure that I concur with that. There was an accompanying editorial to this paper, as is true with all editor's choice. I encourage you, when you're reading an editor's choice paper in the Respiratory Care Journal, to hop over and look at the editorial. It's always a nice addition to the study. So I do want to take just a brief moment and hit on some of the things that were discussed in the editorial, some good points made over there. So the author of the editorial pointing out, and I think we would all agree, that biofilm is really complex and does play a significant role in the development of ventilator-associated pneumonia. He did note that secretions above the cuff also contain pathogens and are responsible for VAP. Also noting here that suctioning is really important, but can play a role in the development of VAP because it could dislodge biofilm from the wall of the ET tube, allowing it to travel into the lower airways, so something to think about. But due to the complexities of VAP, the author of our editorial pointed out it's really unlikely that any one single intervention could be responsible, even if it's a really effective intervention, could be responsible for overall reducing incidence of infectious ventilator-associated conditions. This is a direct quote from the editorial. The failure to improve important patient outcomes in studies examining ET tube cleaning and preventing aspiration around the ET tube cuff is confounding. I agree. It's very interesting here that we know that these tube scraping devices can remove mucus and biofilm from the airway, but it just isn't showing impact on clinically significant indicators. So that's a little frustrating, right? It just intuitively you think that would be impactful, but in this case, it just didn't prove itself to be the case. Which really brings me to the importance and value of publishing negative findings, right? I think publishing negative findings is just, if not more important than publishing positive findings, right? Really trying to understand what works is important, but also understanding what doesn't work can really help to inform future studies and guide the direction of research in another way, or looking at different things that might actually get us to interventions that do have impact. When I think about the publication of negative findings, I really think about Thomas Edison, right? So he said something to the effect of, I've not failed, I've just found 10,000 ways that don't work, right? So this is an example of one of maybe 10,000 ways that we have found doesn't work to reduce duration of mechanical ventilation or those secondary outcomes that the authors looked at. Kind of interesting, frustrating, but interesting. Okay, so in conclusion, rounding this whole thing up, so this study did not find any impact on the duration of mechanical ventilation, length of stay, either in the ICU or overall hospital stay, time to first successful spontaneous breathing trial, or incidence of VAE. Additional studies are needed here to determine the impact of ET tube scraping devices on VAE, so would love to see a study powered to assess that. And then which patients would actually benefit from tube scraping. We just don't know that yet. So looking forward to seeing more work done in this area. And with that, I will conclude my review of the paper and would be happy to field any questions that you may have.
Thank you, Dana. Wow, what a great presentation. I was particularly appreciative of some of the finer nuances that you pointed out, like the conflict of interest, and then the editorial comments at the end. I just thought that your description of the statistical analysis I thought was spot on as well, especially for, maybe some future and neophyte researchers. But, one of the first questions that came up, and it really touched base really right before the conclusion slide came up, is does this mean there's no role for balloon scraping technology in suction catheters? And I think that you really touched on the fact that there needs to be more research performed in this area, as well as the fact that there is a role to be played, especially for those with narrowing of the lumen size as a result of the biofilm and secretions.
Yeah, I agree wholeheartedly. I think it's, that's part of the frustrating piece, right? Because intuitively you would think that these tube scraping devices would be really impactful. And we do know, like I said, that it gets the mucus accumulation out of there, reduces occlusion, and can reduce raw airway resistance. We just don't know right now which patients really need that. And, that's where I'd love to see the focus of future studies to really help guide us in decision making and which patients would most benefit from tube scraping. I think it's important to note here that tube scraping didn't hurt anybody, right? We didn't see a worsening in outcomes in those patients. We just didn't see an improvement either.
Dana, when you first started off the presentation, you talked about some existing literature in this space, and some of those studies used suctioning protocols, where in this particular case, the suctioning took place based on clinical need and at the judgment of the clinician. I think you really articulated it well, that this is likely a result of what happens in real world. But they did say that suctioning was conducted per department policy, but when they talked about the suctioning taking place, that they spoke of the clinician. Do we know were only respiratory therapists permitted to suction patients as part of this study, or were other clinicians like nurses allowed to participate as well?
Yeah, I think that's a really great question. I will tell you, I've read this study a bunch of times. That was not clear to me that a nurse was not allowed to suction patients. So they didn't specifically call it out. I would assume that we would not have prohibited nurses from suctioning.
Yeah, great point. Another question is that there was the statement that the balloon sweeping suction catheter technology was inserted within 24 hours of intubation. The question was mean time captured on how long it took for that to take place.
Yep, I think that's a good question. I will tell you the authors did not share that data, so I can't answer that question.
And then the follow-up question would be, is that a limitation to the study, and could that data have impacted, the results in any way?
Yeah, that's a good question. If you're thinking about comparison of a patient that began getting suctioning at hour 1 versus hour 24, I assume is what they're thinking in this case. I honestly can't answer that question. Is it a potential limitation? Sure. It could be a potential limitation if they were really skewing out towards 24 hours here. Thinking about what happens in the ICU, my suspicion is that's not how long they really went without having an inline suction catheter in place, but I think it's an interesting question and certainly a consideration here.
So let's see here. We have a question. The devices that are on the market that scrape tubes are recommended to be used prior to the SBT. The limitation that you do not believe in was that this study, some of those patients may not have been clean for a long period of time prior to the SBT.
So let me go back to the limitations here just for a second. So the limitation that I'm not convinced is a limitation is that the suctioning was at the discretion of the respiratory therapist. And I think maybe the heart of this question is whether or not, if it was at the discretion of the respiratory therapist, would they have suctioned and scraped immediately prior to extubation? Again, that's not addressed in the paper, so I can't answer that question. But again, my point here was I'm not so sure that leaving it up to the discretion of the clinician itself is a limitation, as that's what happens in real life, and we really like to have studies that reflect real life.
Yeah, absolutely. We do have another question here, and this is more of an opinion on your end, but can you speculate why the researchers excluded patients who died or received compassionate extubation for the analysis?
Yeah, I think, again, they only excluded them in the per protocol analysis. They were included in the intent to treat analysis. You can see both the data set that included those patients and the data set that did not. Again, no statistical significance in either group. But again, just by definition, a per protocol analysis is just one that excludes patients that didn't follow the regimen as anticipated. So a patient that died during the study would have left the study early, potentially, right? So they didn't complete the full protocol. So that's why they would have been included in the intent to treat, but not in the per protocol analysis. So they're in the intent to treat analysis, just not in that secondary data set.
Yeah. You had talked about VAE. There was a comment that stated, you'd done a great job talking about the power of 0.8. And there was a comment that just says, I think it's important to note that the power was based on the primary outcome. And the numbers that were found in the study were insignificant or insufficient to judge any impact on VAE. So just more of a
the study
comment.
was underpowered for VAE. I agree with that. The authors mentioned that as well. It gives us some insight into the potential impact of that. But again, it's really just laying the foundation for potential larger studies that would be powered to assess the impact on VAE. While Doug is trying to get his sound fixed, I did see a question pop up in the chat. So if you'll humor me, I'll answer it real quick. The results of mechanical ventilation duration. How did the authors calculate the reference for mechanical ventilation duration? And they actually did this based on institutional data. So they pulled out the historical data in the institution for the historical duration of mechanical ventilation, and we're shooting for a 20% reduction in that in this study. And that's how they ultimately determined what they wanted to shoot for in terms of the sample size to get to that important 20% reduction in mechanical ventilation duration.
Dana, can you hear me now?
Hi. Yeah, I can hear you, Doug.
I am so sorry. I have no idea what happened to my technology. I ended up having to switch audio sources. But Dana, it has just been a fantastic presentation today. To the audience, I apologize for our technology lapse, but that's what happens in today's world of technology. So I appreciate you hanging with us. But Dana, thank you so much again for joining us today. We will wrap up today's presentation, and thanks for all who attended today's webinar. Please be sure to join us for our next broadcast on September 13th, when the AARC Ambulatory and Post-Acute Care Specialty Section will present a webcast provided by Amy Treese and moderated by Kim Buckley on respiratory care coordination, building respiratory support throughout the care management team. Thank you again, everyone, and have a great day. Anjali, I will turn it back over to you.
Great, thank you. We would like to thank our speakers for sharing their excellent presentation, and thank you also to our participants for joining us today. If you are a group participant, please have your group leader submit your information to the group attendance tab to be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This concludes today's presentation. Once marked concluded, the system will automatically submit for credit for you after you complete the survey. You can check your status in the credit submission tab. We hope you all have a great afternoon.